So hello everybody, Assalamu alaikum warahmatullahi wabarakatuh, and welcome to this session in the cornea series. And I would like to thank Dr. Nancy Raqqad for accepting the invitation to present her nice talk about the decompensated cornea. Of course, everybody knows Dr. Nancy Raqqad because she has been with us since we started the cornea series 3 years ago. And Dr. Nancy is a consultant ophthalmologist in the Royal Medical Services in Hussein Medical City in Amman, and she is the head of cornea branch there. Of course, I want to thank you as well, Professor Tarek Katamish from Egypt for accepting the invitation to moderate this session. And Professor Tarek Katamish is a very well renowned figure in lamellar corneal surgery. As everybody knows, he is a professor and former head of ophthalmology department in Cairo University. So thank you both for being on this session on board, and I'm listening as a student. So Dr. Nancy, the stage is yours.
Thank you very much, Dr. Mazen, for this introduction. It's an honor to be with you, and time flies. I can't believe it's almost now 3 years since we started this. And I'm very honored that Dr. Tarek Katamish is moderating this session with me. And I would like to talk about corneal decompensation and all what a general ophthalmologist needs to know. So before we start, this is a basic picture or photo showing the layers of the cornea that we all know. Starting with the epithelium, the Bowman's layer underneath, the stroma, which is the largest segment of the cornea, and then the Dua's layer, which was omitted from this old photo, and then which is the pre-Descemet layer, and then the much cherished Descemet membrane that covers the endothelium under it. So, and we need to look at this carefully because we will discuss a lot of things during the talk. Now, a very important question that I'm always asked, what keeps the cornea clear? And it is multiple factors. And to me, the most important factors that keep the cornea clear are 5 factors. The first one is the stromal swelling pressure. And the normal stromal pressure is usually 55 millimeter. And we have always a word saying about the imbibition pressure, which is a negative pressure exerted by the glycosaminoglycans, the sugars in the stroma that draw fluid into the cornea. And usually, the intraocular pressure is a combination between the stromal pressure and the imbibition pressure, and they always counteract each other in order to form the intraocular pressure. So a stromal pressure is also a tendency to draw fluid into the cornea. Now, the barrier function, and we have 2 barrier functions of the cornea, the epithelial barrier function and the endothelial barrier function. The epithelial is the zonular occludens, and they are very strong tight junctions, and they are 200 times stronger than the endothelial macular occludens or tight junctions, and they are much more important in preventing fluid from trickling into the stroma than the endothelium. And the third factor is the endothelial pump that we are all aware of, which is the sodium potassium ATPase pump that works by active transportation of the fluid outside of the cornea and trying to work against the accuracy humor from getting into the stroma. We have also the tear evaporation, which plays a factor in keeping the cornea dehydrated or well hydrated, let's say. Although this is a temporary measure, but it also helps, does a good job, a role in maintaining the corneal clarity and hydration. And last but not least is the intraocular pressure, which is a very important factor also in keeping the cornea clear. We all know that if the intraocular pressure exceeds 50 millimeter mercury, the stromal epithelial edema occurs and the cornea swells. And also sometimes it could be a normal IOP, but there is a low stromal pressure that allows the fluid into the cornea. And such as in cases of endothelial dystrophy, the stromal pressure usually is low, and this allows fluid into the cornea and makes it swollen. If these are the things that affect, make it or maintain clarity, what affects the clarity of the cornea? And I like to divide this into 2 categories. The anatomical or inherited factors that I classify into dystrophies. We all know the Fuchs endothelial dystrophy, congenital hereditary endothelial dystrophy, posterior polymorphous corneal dystrophy, and ICE syndrome. These are inherited cases, and also the glaucoma that can be inherited or acquired. Also, there is a genetic predisposition. These are factors on one side, and the acquired side, there's surgery, and mostly the phacoemulsification or cataract surgery, trauma on one hand, drugs that can cause corneal swelling, preservatives if they are abused or overused inside the eye. Chemical burns can cause corneal swelling and sometimes inflammation or infection, especially in cases of herpetic infection and endotheliitis. Now, it's very important before talking about corneal edema is knowing what are the gadgets in order to diagnose and to confirm the diagnosis of corneal edema and swelling. First of all is the slit lamp examination. And we can see that there is swelling in the cornea, whether it is the stromal swelling or in the advanced cases, sometimes bully or thickening of the cornea itself. So this is the basic slit lamp examination. If it's not possible, you can do a central corneal thickness to measure the thickness of the cornea to see if it's swollen or not. Usually the thickness is up to 550 plus minus 20 microns. Above than that, it is a swollen cornea. You can use the pentacam, the shine flag images. It gives you a cross-sectional cut into the cornea that you can also quantify and diagnose if there is corneal swelling or if there is anything abnormal in the layers of the cornea. Also, if you are in doubt and suspecting that there's a weak cornea, you can do a specular microscopy, and this gives you an idea about the number of the cells, also this central corneal thickness, the shape of the cells, and also if there is any abnormal enlargement of the cells, and we'll talk about this shortly. And last but not least, and I think this is the most important gadget to be in the hand of the anterior segment surgeon, which is the anterior segment OCT, that is the most accurate to specify, quantify, and diagnose cases of corneal edema, and also in order to elaborate more on what are the causes and what and the post-operative, if you are going into surgery, results of our surgery in cases of lamellar procedure. Okay, let's go back to the signs. What are the signs to look for if you are suspecting corneal edema? And we're talking about basics now. First of all, the patient could come with a hazy appearance of the cornea. The first sign of endothelial dysfunction or decompensation, let's say, is the epithelial edema. And the epithelial edema ensures, and especially if there is disintegration of the tight junctions and the desmosomal attachments on the epithelial side, because the water is trickling into the cornea before the stroma swells, and we see epithelial edema as a sign of reverse staining. We do use fluorescein staining, and we see cystic changes in the epithelium with intervening stained spaces, and unlike the stromal edema. And this is differentiated, and it's one of the earliest signs of endothelial dysfunction is the epithelial edema. Now, the other thing that ensures if we left it and
Dr. Nancy? Dr. Nancy? We cannot, yeah, we cannot hear you. Dr. Nancy, we cannot hear you. Dr. Nancy, we cannot hear you. Okay. Maybe net connection.
Yes, maybe. It's coming back again.
Yes, Dr. Nancy, we can see you now.
Can you hear me?
Yes, but it seems that
Hello?
net connection is slow.
When did you lose the? Where should I go back to?
The signs of corneal edema.
Oh, so still, okay. All right, let's go back and talk about signs of corneal edema. Now, the first and earliest sign of corneal edema is the epithelial edema.
Can you share your screen, please?
Oh. Okay.
Yeah, this slide.
Yes, okay. So let's go back and talk about signs of corneal edema. The first and earliest signs of corneal edema, especially if we're talking about endothelial dysfunction, is the epithelial edema, or what we can detect on fluorescein staining as reverse staining. And what happens is that you see the stroma is a little bit kind of normal. You see that there's a hazy appearance of the epithelium. You use a fluorescein stain, and on the slit on the blue light, you can see that there are cystic changes on the epithelium with intervening spaces that are stained with fluorescein. And this is what we call reverse staining in cases of epithelial edema. And this is very pathognomonic of endothelial dysfunction. It's important to differentiate this kind of epithelial edema or reverse staining from the stromal edema that happens usually not only in decompensated cornea or abnormal endothelial function. It happens also in cases of infection, especially herpetic keratitis, because usually sometimes undiagnosed or underdiagnosed cases of herpetic keratitis, especially disciform or stromal keratitis, they come as only stromal edema with no other symptoms. So this is a very important also sign to differentiate both. Now, if the edema or the dysfunction is massive, then stromal swelling ensures. You can see sometimes Descemet membrane falls as well, and this can be seen in infection and inflammation, also in affection of the Descemet membrane or trauma or post-cataract surgery. And also you can see it in cases of dystrophy. And sometimes in trauma or post-cataract surgery or fecal emulsification, you can see a Descemet membrane defect, and usually in the earliest phases before the edema obscures the vision or the visualization. And in more advanced stage, you can see bully and detachment of when the anterior part or the desmosomes and the epithelial attachments are sloughed off, and fluid pockets, they appear inside the epithelial spaces, and then bully starts to occur. And last, but we don't want to reach that stage, is the encroaching vessels from the periphery onto the cornea when there is long-standing corneal edema. I will concentrate on two major factors that cause corneal edema, and it's important to deal with them from the beginning. The first one is the Fuchs endothelial dystrophy, which is the most common cause of endothelial decompensation or corneal edema in the Western world, let's say, and cataract surgery with bullous pseudophakic bullous keratopathy being the most common cause or the most common indication for lamellar corneal procedures in our part of the world, and also a very important cause that is also not that much diagnosed well in the early stages of after cataract procedure. Now, why does corneal edema happen after cataract surgery? And it's important to answer this question. Now, sometimes the patient is not properly evaluated before surgery. He might have had endothelial disease and he was not evaluated for that. So the surgeon or whoever would be surprised that after surgery, the patient has developed some corneal edema. He would have sometimes a lengthy procedure that caused a problem and shock to the endothelial pump mechanism and causes fluid to trickle into the stromal spaces. And next day there will be some folds and some that we say striate keratitis, and striate keratitis are a sign of that the endothelium has been shocked. Of course, from the stress of the surgery, does not mean necessarily that it is affected by decompensation, but this means that it has been stopped and halted for its function for a while, and it will need time to recover. Sometimes there would be a complication during the surgery, and the fecal emulsification has taken a longer time than usual. Sometimes drugs can be used in abnormal concentration that will affect the endothelium, such as acetylcholine or myocol, that it is not, if it's not diluted, might cause a shock for the endothelium and cause edema after that. As we said, long operative time, sometimes retained viscoelastic or a high intraocular pressure. If the eye is left with a high pressurized anterior chamber, especially if in the presence of vulnerable endothelium, would cause edema in the next day. Sometimes if the surgeon is inexperienced and there had been iatrogenic trauma or mishandling of the tissue, and there would be inadvertent touch of the endothelium, this would cause also, especially in older eyes, this would cause also edema. Certain intraocular lens designs, which I do not prefer, which is the angle-supported anterior chamber lenses, because not only they cause touch to the endothelium, they also cause some kind of inflammation, and the risk of decompensation usually is up to 10% in these eyes. Okay. Okay. Now, there's an important question to ask. Does phacoemulsification cause Descemet membrane detachment? And I forgot to say that, of course, if we use like an extracapsular cataract extraction in patients with hard cataract, and there was a lot of manipulation inside the eye, this is associated with edema more often than in the usual phaco. Now, the other question is that does phaco cause Descemet membrane detachment? Because we are likely to see a lot of this term, let's say, in the recent years. So does phaco per se cause the Descemet membrane? Did the surgeon do a Descemet membrane detachment and did not notice, and you're seeing it after surgery? No. To answer the question, yes, it can. Phacoemulsification can cause detachment of the Descemet membrane. And to be honest, detachment of the Descemet membrane does not need to be a complete opening of the Descemet membrane. It does not need to be only a separation from the Descemet membrane and the stroma. Sometimes detachment has a lot of phases. It can be phase 1, phase 2, or phase 3, or 3 stages of detachment. The third stage is where it is completely separated from the stroma. The second stage is that the Descemet membrane can be separated from the pre-Descemet layer. And the first stage, which is most commonly that we see, is that the shocking of the Descemet membrane and the cessation of the function of the sodium-potassium ATPase pump would cause fluid, as we said, to go into the stroma. And this causes thickening and undulation or wavy formation of the Descemet membrane. And this is one of the earliest stages where the Descemet membrane is said to detach. Now, if the stroma fills with fluid and the proteoglycans or glycoproteins, they are all carbs and collagen and protein. If they swell with water, they swell and they push the Descemet membrane posteriorly. And this can be documented if you have the luxury of an anterior segment OCT intraoperatively. Of course, we don't. I don't know if there are other centers or Dr. Tarek, if you have it at your center, or you can document it afterwards if you do an anterior segment OCT for the patient who is swollen and he has Descemet membrane striate keratitis or folds in the first few days after surgery. You can take him to the anterior segment OCT and document the thickening and the posterior undulation of the Descemet membrane on OCT. And as we said here, older age, it happens in older age if the procedure is lengthy, if the endothelium is weak. And as I said, it's believed that the Descemet membrane folds after cataract surgery are caused by the acute edema of the corneal stroma that pushes the Descemet membrane posteriorly, forming this layer. Now, the second cause of edema is the second most important cause of corneal edema or decompensation is the Fuchs endothelial dystrophy. And I want to focus on the Fuchs endothelial dystrophy because usually the patients that come to us, they come or reach us as cornea surgeon in the stage 4. While it can be handled by general ophthalmologists and junior ophthalmologists where they are in stage 1 and 2 and sometimes 3. We can divide Fuchs endothelial dystrophy into 4 stages. The stage 1 usually is asymptomatic, but the patient, if he is examined properly on the slit lamp, you can see that there are non-fluent gattata all over the cornea. You can do a specular microscopy if it is available to document that there is either enlargement, polymagatism, pleomorphism, or the number of cells in the cornea, although sometimes the cells might have more than 2,000 count, but you can at least document that. Now, the stage 2, usually the patient becomes slowly symptomatic, and especially in the morning. And we ask the patient, do you feel that the cornea or the eye or the vision is hazy in the morning and it gets better by day? Usually their answer is yes. So they are partially symptomatic. Sometimes the gattata, when you look at the slit lamp, you see areas of gattata coalescing together. And the reason why that the visual symptoms, they improve by day is the function of the tear film. In the morning, the tear film would have not evaporated and would have caused a moist chamber for the epithelium and endothelium, so the fluid would not be removed out of the cornea. As the day goes by, evaporation occurs, and this clears the cornea better. Now, in stage 3, the function of the endothelium pump is so compromised, the corneal edema is evident, and it does not change. It does not differ between day and night. And in stage 4, you have a long-standing edema, you have bully, sometimes scarring, and sometimes starting vascularization. And this is where all patients with stage 4 Fuchs endothelial dystrophy are sent to the cornea specialty. Now, an important question to answer is how to tell this is a corneal edema, when to refer him, what to do if I suspect it. Now, the most important thing for any surgeon or any doctor examining a patient and suspecting this is a patient who has a weak endothelium, or this is a patient who is undergoing corneal decompensation, I want to stop this before it, is to anticipate. If you have it in your mind, you always find what you look for. So if you have it, keep it in your mind. If you suspect this in one eye, look at the other eye. If there is a sign of edema in the post-operative period, let's say of one eye, look at the other eye. You might find gattata that you haven't seen in the first eye. And if you see a gattata, if you want to take the patient to operative room, it's very important to plan for it. So examining the patient thoroughly is very important and a part of solving the problem. And if you are in doubt about this patient going into surgery or coming out of surgery and you want to protect the other eye from going to the same fate, is to obtain a specular microscopy. You look for the count, for the thickness, if there is polymagnetism and pleomorphism. We all know that the endothelium does not regenerate, so if it is decompensated or if it is weak, then the defect is compensated for by the cells becoming enlarged, they becoming different in shapes, and this is a sign of there are defects and dropouts in the endothelium. Now, if you're taking the patient to a phaco procedure, it's important if the cataract is not that dense to protect it. And how to protect it? Either you have two options. Either to use the soft shell technique, which is to use a dispersive OVD and then two types of OVD during surgery to cover the endothelium, and then to use your phaco with gentle settings. But usually it's important to give a senior surgeon to do the procedure if you have severe gattata, if the patient is one eye, if the first eye is complicated or this eye is complicated, it's better not to touch these patients and to refer them to a senior doctor. As we said, it's important to use gentle settings and adopt a direct chopping technique because you want to decrease or minimize the phaco power as much as possible when you are operating these patients. Now, the other option is that you tell the patient that you might need to have what we say a combo, which is a phaco DSAEK or a phaco DMEK at the same time. So you do the surgery because you are sure this patient will decompensate and the cornea will not withstand such a procedure. Most of our patients in our part, because of the scarcity of the corneal tissue, they prefer to do the surgery, wait until they see the decompensation of their own eyes, and then they come for lamellar cornea surgery. But sometimes some people, they would just can't live with the decompensation with a little bit of a push for a few years before going into a lamellar procedure. One of the tricks that I teach my fellows is that to protect the endothelium at the end of a surgery, whether it was lengthy surgery, hard cataract, there a pseudoexfoliation present, if there's anything, a lengthy procedure, anything that is fishy about phaco emulsification procedure, or even sometimes when I do a PKP or any kind of corneal procedure with a lot of maneuvering inside the eye, is to use an air bubble at the end of the procedure. And the rationale behind this is that any surgical intervention, all the fluid that we push into the eye and irrigation, it, as I said in the beginning, they cause a shock to the sodium-potassium pump in the endothelium. And also the zonular occludens inside and the zonular attachments in the endothelium, they just get stopped out of function for a certain part of time, they get halted. And so in order to give it some time to recover and prevent any fluid from coming from the aqueous into the cornea, is to use this shield of air bubble. So by next day, you will see the cornea clearer than if you did not use the air bubble. And you will give the eye some time overnight to recover until you see the patient next day, and preventing the aqueous from sticking or trickling into the stroma. Now, one of the tricks also that I say is that try not to shave the epithelium. I know we all do it sometimes, especially when we're doing lamellar surgery and the view is hazy. Vitreoretinal surgeons, they do it a lot of times, that they shave the epithelium in order to visualize better the eye from inside. I prefer not to, because if you shave the epithelium, you have rid the eye from the most important barrier, the zonular occludens in the epithelium that protect fluid from going into the cornea. So if you have a short term, like 10 minutes or 15 minutes phaco, that's fine, you're doing okay. But if you have a lengthy procedure, trust me, the cornea will become hazy slowly. And it's not because the endothelium is bad, it's because that you shaved the epithelium and allowed the water to get into the stroma. And avoid lengthy surgical time. As you said, especially if we shave the epithelium, avoid lengthy surgical time. Okay, let's suppose that you are stuck and the cornea started to overhydrate and swell. What to do? First thing, we want to recognize this and we want to help recovery. Try as much as possible to give or to handle such a case, especially if it took a long time, to the next senior surgeon or the senior surgeon next to you if he is or she is available. And we want to now kick some things in order to help the eye to recover. It's very important to avoid ointments on the surface of the cornea, especially if the endothelium is decompensated. Why is that? Because of two factors. The first factor is that the ointment is heavy. So there would be a mechanical obliteration or a mechanical or a physical barrier on the top of the epithelium. And that will interfere with evaporation, because if you want to help if the tears help by evaporation, you have put an ointment that is heavy and evaporation is then stopped. So this factor from the 5 factors eliminated. So I try and avoid ointments. I prefer to use drops. And if you have shaken the epithelium for one reason or another, and it needs to cause or have better attachments, it's better to use drops in order to help the movement of the cells from all over, especially from the stem cells into the center of the cornea. Second thing, you can help the eye with using hypertonic eye drops. Hypertonic eye drops, they work by drawing fluid outside of the stroma to the outside to be evaporated with the tears. It's important to decrease the intraocular pressure, because decreasing the intraocular pressure minimizes the fluid or the aqueous that is coming into the weakened endothelium and the stroma. It's important to increase steroids, because some part of the or some of the mechanism of the corneal decompensation is an inflammatory mechanism, and because of the inflammation going all over, even surgery triggers the inflammatory cascade. You want to decrease this, so increase the steroid drops. And this is for the earliest cases of the edema, let's say post-operatively. Now, what about advanced cases? Advanced cases, we're talking about bully, we're talking about sloughing, we're talking about pain and haziness. It's good to use, now you're going into the symptomatic relief. You can use a bandage contact lens in order to decrease the stretch on the epithelium from the enlarging bully. We used to do in the past puncture of the bully to decrease the patient's pain if it is a large bully. I'm not seeing this trend anymore. I'm not using it as well, because I'm not seeing that much patient coming with large bully with and severe pain, especially in cases of recurrent erosion that they have deficient desmosomal attachments. Sometimes we need to scrape it off to allow a better or healthier epithelium to bridge the gap. It's important to load the patient with vitamin C, because it helps a lot with the healing of any bully or defect that has happened. And recently also we're loading the patients with vitamin D, that was found to have a very important role in the connections of the collagen inside the stroma. Now, it's important to wait. Sometimes if I feel that the cornea has decompensated a little bit and there are signs of straight keratitis, especially after surgery, I wait. And I wait usually up to 2 months to see if there is signs of recovery or not. And I wrote here in the slide, not until 3 to 6 months, because you don't want a long-standing decompensation or edema to occur, because there would be no way back. So wait before you judge this patient and talk to him. You can tell him you are in the middle zone of you might recover or not, according to all the factors that you've used. But after 3 months, if the patient is not recovering, it's important to sit with the patient and tell him or tell her that surgery is the salvage of the state you are in. Now, the signs of the severe state, as we said, it starts at epithelial edema, then it shows a stromal edema, bully starts, the central corneal thickness, if it is more than 1,300 microns, it will not recover. This will not go back to normal. And if the vessels started to encroach, this is a long-standing, and please don't wait for the vessels to start encroaching on the cornea.
Dr. Nancy,
I just want to give...
Dr. Nancy, vitamin C, is it oral or topical?
Oral, yes. Yes, oral vitamin C. There is now a new preparation of ascorbic acid drops to be used on the cornea, but not released, not approved yet. But they are on the way. But I mean oral vitamin C, 3,000 milligram daily. So 3 tabs of 1,000 milligrams vitamin C daily.
Thank you.
Okay, now let's talk a little bit about the role of the OCT in corneal edema. OCT now is all over the market, and I consider it to be a fantastic tool in the hands of an anterior segment or corneal surgeon for many reasons. Sometimes the patient comes to you with an opaque cornea. You don't know what happened. The patient tells you that there has been a complicated procedure several months ago, and he does not know what exactly the complication was, and you want to know what exactly to do. If you reach a cornea that is hazy and you cannot visualize the anterior segment, usually this is no place for a DSAEK or a DMEK, usually, but sometimes it gives you a clue. So it's the best tool in hazy corneas in cases of difficult visualization, and also in cases of doubted decision-making, especially after phaco. You might see a patient with undulated, who has referred to you with uneventful phacosurgery, but you can see that the cornea is swollen and you don't know why, and there's no any other signs of anything wrong. And you put the patient on an OCT, you can see that there is a little bit of thickening, or there are pockets of fluid and a little bit of detachment of the Descemet membrane, and you can just save the patient by doing some air bubble and tamponading, and then and this saves him from a major lamellar surgery, and at the same time it can give you some time to buy and proceed into a very important surgical intervention. So what to look for, as we said, either a frank detachment of the Descemet membrane, swollen stroma, of course, a wavy Descemet membrane in the earliest stages, and a thickened membrane also. These are the signs of Descemet membrane edema or swelling. Now, after we finished all this and the counseling and all what we had to do and the gadgets, and the patient now is 3 months post, let's say, phaco, or 3 months post treatment for Fuchs endothelial dystrophy, and he's in stage 4 dystrophy, or sometimes stage 3 that's not resolving, it's time to refer this patient and expect what to do for him. In the past, it used to be a complete transplantation. Now we have the luxury of the selective corneal transplantation or keratoplasty, and we have 2 kinds of winner procedures that can save the patient from the state of the corneal edema. We have the Descemet stripping automated endothelial keratoplasty, which is DSAEK, and we have the Descemet membrane endothelial keratoplasty, which is DMEK. And we'll talk about the DMEK first, which is the most superior procedure to be used in cases of disease and dysfunction of the endothelium or disease of the Descemet membrane. It is superior in the visual results, but the problem and the drawbacks about it, and I'm glad that Dr. Tarek we will have a good discussion about this after I finish, is that it needs a good visualization. You need to see well in order to put a DMEK graft in. You need almost a perfect eye with a good iris, and these are best for Fuchs endothelial dystrophy up to stage 3 cases. And as we said, it needs good visualization to perform. Now, the DSAEK, on the other hand, and especially the ultra-thin DSAEK, it's the same selective replacement of the endothelium, but we take a thin lenticule of the thin lenticule of the posterior stroma, and it is attached. Now, the visual rehabilitation after DSAEK is less than DMEK. Let's say DMEK is superior in obtaining 20/20 vision. DSAEK is also good in obtaining up to normal vision, especially if it's ultra thin, and it is good in patients who have complicated surgeries, complicated eyes, and complicated phacos, where they can save the patient's a problem. I just want to show a quick video highlighting how the DSAEK is done, and you can do. Says cannot play media. Okay. Let me just see if I can play it from here. Okay. I cannot play the video. I don't know why. Okay, let me just say the steps. Steps of DSAEK. The cornea is prepared with the stripping of the endothelium or Descemet membrane, and then a lenticule of the endothelial. Yes.
Yeah, share the slide and then double click on the video itself, not on the arrow. I mean, share the slide from down.
Share like this.
Okay. Yes.
And
try to double click on the picture itself. Double click. No, it's moving.
It says cannot play media.
Okay.
Let me see if I can open it with.
Do you have the same video on your desktop?
Yes.
So if you have it, you would like to play it from the desktop, that would be great, please. If you can find
I
it.
will. Just hold on. Yes, I will find it. Hold on. Try to play it from this.
Yeah, you find it?
You can see it, huh?
No.
Your screen sharing is paused. I will share this screen, the other one. Hold on.
Yeah, the other one, yes. Before sharing, you will find an option down left, like share audio, something, optimize video, 2 options down left. When you open to share screen, you will find 2 options down left. Did you find them?
Share sound, optimize video clip.
Exactly. Please click both. Yes.
Share sound and optimize video clip. Okay.
And then share the screen now.
Okay. Can you see it? Yes?
Yes. Yes.
Yeah?
Yeah.
Okay. Okay, this is how we do DSAEK, ultrathin DSAEK. We score the endothelium. We do like rexes to remove and strip the endothelium and the Descemet membrane gently out of the cornea. I do it usually under air bubble. It makes it easy for me to visualize because most of the patients, they come with a really severe swelling of the cornea. And I tug it in towards the center. And as you can see here on the screen, where the folds of the Descemet, and then I just take it out from a side wound with a forceps. And after that, I use an anterior chamber maintainer on the side before I fashion 2 wounds. The wound is 5 millimeter usually in order to insert the corneal ultrathin DSAEK lenticule. I make it large in order not to crush the tissue in the forceps. And I make sure that this is the boosting glide. I make sure that it fits into the wound before I go and fashion the cornea. Now this is the cornea. There are 2 sources. You can just order it from the eye banks as a pre-cut cornea, or you do it freshly cut in the operative room. Labeled with a letter. Usually I label it with the F letter to know my orientation, and then we take a punch, usually between 8.25 millimeter. I think this video is stopped. I will share the other video and show you how we pull. And then we pull the lenticule inside the eye. And we insert the graft using, there are multiple ways to insert the graft. I like to put it with the forceps, and I keep the AC maintainer in. I put some air under the lenticule, and then I remove the AC maintainer, and then I just centralize the graft and keep the eye hard for 40 minutes, 100% airfill, and just wait for the cornea to attach. Okay, now I will go to the other original presentation. So this is for when we come to talk about DSAEK. And then, thank God that the DMEK has only photos, not a video. The other option is that when we have good eyes, especially where there's Fuchs dystrophy, and the cornea is regular, and the pupil is regular, and there are not a lot of complications in the eye, we choose the DMEK over the DSAEK. And the DMEK, we do get the corneal button in two ways. Either we harvest it from a previous fashion doll, deep anterior lamellar keratoplasty. We take the endothelium and we use it for a patient who needs a DMEK, or we order it pre-cut from eye banks, and it comes stained sometimes and stamped. So it's very important to stain it. It's very important to have a good visualization to know which is the orientation of the graft. And the thing about the comparison between the DMEK and DSAEK is that in the DSAEK you need a good AC and a good anterior chamber, a formed anterior chamber, in order to insert the lenticule, while in DMEK, on the opposite, you need it to be shallow enough in order to allow the scroll or the graft or the DMEK to open up. And you can open it with a lot of maneuvers, the double tapping with the cannula, and or you can use an air bubble to iron it and move it all around. And once it has opened, then you just quickly put an air bubble underneath it and wait some time, and it will attach. The DMEK is a beautiful surgery in well-constructed eyes when you have a very good orientation of the graft. And believe me, it's not as so. Just a quick comparison between DMEK and DSAEK. The DMEK learning curve is difficult.
Dr. Nancy.
Yes.
Yes. Your voice disappeared when you said, "Believe me." Believe you in what?
Believe me that the procedure does not look as easy as the pictures are. There's a lot of hustle and manipulating before it opens up.
Okay, so we believe you now. Okay, you can go on.
So yeah, now before we recap, a quick comparison between DSAEK and DMEK. DMEK's learning curve is more difficult compared to DSAEK, especially if you do not have to fashion the graft itself. If you bring it pre-cut, there's no need of microkeratome in the DMEK. You need it in the DSAEK, so it's a cheaper option compared to DMEK. The graft manipulation is difficult in DMEK. Sometimes in early learning, there's more wastage of tissue, especially if trying to fashion the graft yourself, and more graft dislocation for beginners. There's no stromal interface in DMEK. It's usually sticks, if it's done well, it sticks to the endothelial surface beautifully, and the speed of visual recovery is very rapid. There's no hyperepic shift, the one that we see with DSAEK, although with ultra DSAEK, this is negligible. And the cases of who achieve 20/20 vision is much more with DMEK than DSAEK. As you said, there's hyperepic shift in the classical DSAEK, but now we're not very little surgeons are dealing with DSAEK. We're now fashioning the ultra thin, which is less than 100, and sometimes it's nano thin DSAEK, which is a graft that's less than 50 microns, in order to be able to reach the results that DMEK can achieve in more difficult eyes. And this is how the eye looks like after a classical DSAEK procedure with the air bubble in place the second day. And I'm happy now to be questioned and to hear from Dr. Tarek also. And thank you.
Thank you very much, Dr. Nancy. Great presentation. Dr. Tarek, the microphone is yours now.
Okay. Thank you very much, Dr. Nancy, for this comprehensive talk about the very important topic, the corneal decompensation. Of course, it shows that you have a great experience in corneal surgery as well as ocular surface surgery. I have just some highlights on parts of your talk, if you allow me to have some comments and to ask you some questions.
Yes, please.
Yes. First of all, you have mentioned in
Please
your the causes of corneal edema, the herpetic endotheliitis. Yes, this is a very great topic, and it's very important to and I just want to ask you, how to differentiate between herpetic endotheliitis and Fuchs dystrophy, because sometimes we have the patient with herpetic endotheliitis, and some people do not recognize the pathology of this case and go directly for DMEK. So can you tell us, please, how to differentiate between herpetic endotheliitis and Fuchs dystrophy?
Yes, thank you. This is a super question. Thank you very much for this. Now, herpetic endotheliitis, this is what I said at the beginning. Sometimes herpes comes as stromal edema, and it is underdiagnosed. Now, there are signs that the patient has a herpetic endotheliitis or herpetic stromal keratitis rather than a decompensated cornea. And these, we have to look for other signs. Sometimes you see a localized edema. A localized edema is seen in herpetic keratouveitis or herpetic keratitis. That is not seen in Fuchs endothelial keratopathy. Fuchs endothelial keratopathy usually comes in a more widespread and a more generalized edema, while in herpetic keratouveitis or keratitis comes as a localized edema. So whenever you have a localized edema, you have to suspect there's herpes. The second thing, if you have a localized edema, you have to look behind the edema. Usually you see KPs. So they could be faint, they could be old, but usually you see KPs behind the edema. And this is a very important factor to differentiate that this is herpes. The third thing is that you have to look at the iris. Sometimes you have a patchy iris atrophy. Sometimes you can see it does not need to be very large, but you have to look for a patchy iris atrophy. In herpetic keratouveitis, sometimes you see the triad of Descemet membrane folds, stromal edema, KPs, and the iris, as you said. This is a pathognomonic for herpes, and it's very important to ask the patient: does your eye become red often? And he mentions this. Oh yes, I used to have viral infection every now and then. And this is one of the very important questions to ask a patient if you suspect this. This is the first thing. The second thing, usually Fuchs endothelial dystrophy comes in two eyes. Herpetic keratitis rarely comes bilateral at the same time. Usually it comes in one eye, it hits it again and again in the same unilateral eye. It's very important you move your microscope or slit lamp and to look at the other eye, examine it for gattata. Sometimes in Fuchs endothelial dystrophy, they don't have to be symmetrical, but the involvement is always bilateral. So look at the other eye, you would see gattata. And or you could see a more advanced disease in the other eye, which highlights this is, yes, decompensated, not herpetic. And it's always an addition, it's not a luxury, that you can do a specular microscopy before sending a patient to surgery. So thank you for the question.
And what's your preferred method of treatment? You use topical antiviral, or you should use systemic antiviral for this herpetic infection?
The only time I use topical antiviral is when I have primary epithelial herpetic keratitis. And this is the only time in my whole practice that I use something on the cornea when there is herpetic keratitis. Herpetic stromal keratitis is an autoimmune disease. It's an inflammatory process. So you have to bombard the patient with steroids, topical, and then I always use an anti-cover with oral antiviral cover. Unless I have an ulcer, of course. If you have an epithelial defect associated with it, I use a topical treatment. But if you have just stromal edema and signs of herpetic endotheliitis, I always use oral antiviral for a long time. And
what is the dose and for how many months?
Okay, if the patient comes with an acute stage, I use it 400. Acyclovir is available in Jordan. I use acyclovir 400 milligram 4 times daily for the first few days or weeks until the inflammation or infection subsides. It's inflammation mostly, it's not an infection. And then I put him on a maintenance dose, which is 400 milligram twice daily for 1 year. And I explain if this is a recurrent situation, you have to have a maintenance dose. And I keep the topical. If there is a haze, I keep the topical with a mild steroid for a longer time, but I usually start with the heavy steroids with 4 times daily or 40, and then I taper it to a weaker steroid.
Exactly. You have mentioned in your causes for the corneal decompensation, post-surgical cases, and of course, the most common cause is the pseudophakic bullous keratopathy. But if you allow me to add a very important cause I have seen a lot in my country, which is not FDA approved, the cosmetic iris implant. Unfortunately, I saw a lot of cases of cosmetic iris implant to change the color of the iris. And I have shown a lot of cases coming to me with the persistent corneal edema and iris atrophy and glaucoma. So just I want to mention this cause to be aware of this not an FDA approved procedure. What's your experience in dealing with this such ugly cosmetic iris implants? Dr. Nancy? Dr. Nancy, you hear me?
Yeah, net connection again.
Yes.
Maybe you can take some of the questions until reconnection by Dr. Nancy.
Questions for Dr. Nancy, so I want her to.
Okay, to answer. Okay, so she is joining now again.
Dr. Nancy, do you hear us now?
Unmute, Dr. Nancy.
Unmute yourself, please.
Yes. Sorry for this connection.
Experience in dealing with such iris?
I think these are a crime, to be honest.
Yes, exactly.
These are a crime. I've seen girls and I've seen patients who have not only the cornea decompensated badly, the inflammation has wiped off even the iris, that they have complete iris atrophy. I don't know who does this still, but this is actually a crime. As you said, this is not FDA approved, but yes, it's one of the ugliest causes of endothelial decompensation.
I just want to put a highlight on this issue to be careful and aware of this. Yes,
absolutely. Thank you.
Yeah, you have mentioned in your talk that a lot of causes of Descemet membrane detachment during phacoemulsification. But if you allow me to add another important cause is when you have a tight phaco wounds. If you have a tight phaco wounds and you are introducing the phaco probe snugly inside the wound, and if you are introducing the intraocular lens injector snugly in these tight wounds, it's a very important cause of Descemet membrane detachment after cataract surgery.
Absolutely. It's also an important cause, and it's not observed because the surgeon is focusing on the center of the eye, and also when they come out, that area becomes a little bit whitish, especially if it's tight on the phaco probe, and they wouldn't recognize it until next day that the Descemet is detached a little bit.
I am not a fan of making the smallest wound. I am a fan of large wounds. I am a fan of putting my instrument smoothly inside the eye. Even when I do DMEK, for example, we usually use the DMEK injector through a wound from 2.4 to 2.7. I prefer to have the 2.7 wound to have a smooth introduction of my instrument in my eye.
Yes, respecting the cornea, the tissue. This is what I call respecting the tissue. And there is a term between surgeons, is that a wound-assisted delivery, let's say, or wound-assisted insertion. I don't like this because you don't use the corneal tissue in order to assist you. You can just enlarge the wound just a little bit. 1 or 2 millimeter can make a big difference.
Exactly. You have mentioned also a very important point as regard when you have a pseudophakic bullous keratopathy, you have to spend some time in proper diagnosis, because I have seen a lot of cases referred to me to do DMEK after pseudophakic bullous keratopathy, and I discovered that they are coming with Descemet membrane detachment. And just very simple injection of air bubble will solve the problem. So I want the young generation to be aware of this, that not every case of corneal edema after phacoemulsification means decompensation. Sometimes it's very easily treated by a simple air injection. And if you can't see the Descemet membrane detachment, you can do as Dr. Nancy told us, you do just OCT, it will solve this problem.
Absolutely.
Dr. Nancy, can you tell us the dilemma of having a cataract in a patient with early Fuchs dystrophy, whether to do cataract alone or to do triple phaco-DMEK? You have mentioned this in your talk, but I want to tell me your guidelines of choosing which way you decide to do just cataract only, and you know the patient has a Fuchs dystrophy, or you have to do triple phaco-DMEK or triple phaco-DSAEK. What are your guidelines in making decision as regard this point?
Okay, so let's divide this into two categories of surgeons. If you are a general surgeon in a, let's say, not a center who has this luxury of a corneal or lamellar procedure, you're the general surgeon and you are a very good phacosurgeon and you've seen a patient who came to your clinic who has a Fuchs endothelial dystrophy. First, you explain to the patient that he has a weak cornea, and that you might need to use the soft shell technique. It's very important for general surgeons or ophthalmologists to master the soft shell technique in order to protect the endothelium during phacoemulsification. Now, let's say that the patient has +2, +3 nuclear sclerosis. You use gentle settings and you explain to the patient that there might be a chance he might decompensate, especially older age, and there's a chance that he will get out of it. But it's very important to have this chair time and talk with the patient. And you tell the patient, if you have an uneventful surgery, everything went well, it's fine. Otherwise, I will have to, you might need another procedure, which is the lamellar corneal procedure, and you will be transferred to a more advanced or specialized facility. So it's important to have this chair time with the patient if you are, let's say, a general ophthalmologist, and you do your best. And most of the time, they just will do well, especially if the patient is middle-aged, their count is good, and you've taken all the precautions to do an uneventful phacosurgery. But at least the patient, if he did not recover, he would have known that this option was there. Or even if he might decompensate after 3-4 years, he would just say it's not because of the phaco, it's because my cornea did not last that long. Now, if you are in a tertiary referral center, which we are blessed to be, this chair time is different because we tell the patient, listen, you have a weak cornea, weak endothelium. If he has stage 1 or stage 2 endothelial, nuclear sclerosis, and we can do the surgery, which is this quick maneuver with soft shell technique, and we have the luxury of the specular microscopy to examine him. If let's say between 1,000 and 2,000, above 2,000 count is okay. We're talking about a decompensated cornea, or the count is low. Under 2,000 and above 1,000, we will just go on with the procedure and tell the patient that you might need later on, but we will just go with a phacoemulsification. If the cornea is decompensated, and let's say below 1,000 cells, we will offer the patient a combo procedure, which means that he will need a combo, a triple procedure, which is a phacoemulsification and then a DMEK or a DSAEK. And the offering of a DMEK or a DSAEK, to be honest, is up according to the availability of tissue. So if we have a DSAEK, we offer a DSAEK. If we have a DMEK, we offer a DMEK. Sometimes we don't have either, and we offer the patient to do the procedure and then to bring him back for another graft. So sometimes the corneal source just controls us, the other way around.
Yes. Yes, as you have mentioned, for myself, I have some guidelines whether to go for phacoemulsification only or to go for triple phaco, DMEK or DSAEK. These guidelines are, for example, number 1, the endothelial cell count. If I have endothelial cell count below 700, this is a very risk factor. It tell me that you go better for triple phaco DMEK. And if I have a corneal thickness above 640, this also means that this cornea most probably will not tolerate cataract surgery alone. And finally, if the patient has symptoms, if he has fluctuation of vision, especially at the morning, if he has glare, if he has halos, these are symptoms of the minimal corneal edema. So these are the 3 factors that push me to do a triple phaco DMEK in such patients. Last question.
Yeah, can I ask you something before I forget about the thickness of the cornea? Now, yes. I always say above 1,300, this is severely decompensated cornea, and I forgot to mention corneal scarring is one of the contraindication to do a lamellar procedure. But what thickness do you depend on in going into DSAEK or DMEK? Let's say, do you have a cutoff point? For me, it's 1,300, sometimes 100, 1,200. Do you have this cutoff point, or you do not use it?
I don't have a cutoff number of how much corneal edema is. My most important point for me is whether this cornea is scarred or not. So I look to the stroma. If it is just stromal edema and just fold this membrane, I can do DSAEK or DMEK, whatever the thickness is. But if I have signs of scarring, white lines in the stroma, this means, and sometimes if you have partial scarring, still you can do DMEK because of course, you know, the advantage of DMEK over penetrating keratoplasty is huge. So if you have partially scarred cornea and you can do DMEK with partial improvement in vision, in my mind, it's much better than doing PKB, penetrating keratoplasty, which of course has a lot of problems.
Of course.
The last point before opening the discussion with the audience, that you have mentioned that the two main surgical options for treating corneal decompensation, I agree with you, are DSAEK and DMEK. Just I want to add that there are two other options. I just want to make a very small comment. We have also PDEK, which is pre-Descemet membrane endothelial keratoplasty, in which we implant Descemet membrane, endothelium, and DOAS layer. And this technique is done by doing air injection in the donor and having big bubble type 1. Another technique for early cases in Fuchs dystrophy is what we call DSO, or what we call it Descemet stripping only. The idea of this technique is we make a very small descemetorexis in the center of the cornea, depending on the theory of the migration of the healthy endothelial cell from the previous. So this technique, the DSO or Descemet stripping only, is indicated for the very early cases of Fuchs dystrophy, and is still under trial, and it needs some time to clarify. So before I just want to go for some questions to you, Dr. Nancy. There was a question very early in the session. Any role of cross-linking in corneal edema? Dr. Mazen have mentioned some points while you have lost connection with us, but if you do have any comment on this question, there is any role for cross-linking in corneal edema in your opinion?
I do not use it, but I know that it has a role. Some surgeons and some colleagues, they do use cross-linking, and the rationale behind it is that they strengthen the collagen fibrils connections in the stroma, decreasing the load of the fluid that comes into the stroma, and that's why it is used. Actually, I don't use it, so I don't have that much experience with it. I'm just saying what I read and what I've learned from some colleagues, that they use cross-linking in order to just decrease the load of fluid and water by increasing the attachment inside the fibrillary attachment inside the stromal structure.
Dr. Mazen and myself has also a very limited experience in this aspect, and we don't believe that it works good. Another question: in what parameter in specular microscopy triple procedure is recommended? This is a question asking what is the parameters in specular microscopy which indicate triple procedure.
As you mentioned, for me, it's below a count that is less than 1,000 count of endothelial cells. For you, you mentioned 700. We're talking about the same range. It is important because the cornea will not recover, and we know that. Sometimes the count is very good, and it's important to have as much when we do the. Sometimes if the cornea is edematous, it's important to highlight this, that the machine does not take, the specular microscope does not take the count. So it's important to do it manually. And sometimes you might need to scrape off the epithelium and to know the count of it. But if you reach that stage that the cornea is hazy, it goes without saying that you need to do a triple procedure anyway. But before under 1,000, it's important to do a triple procedure. Otherwise, you spare the patient a second procedure and transplant.
Yes, there is a question, I think you have answered it. We load the cornea with vitamin C. Is it orally or topically? You have answered that this is orally.
We load the patient. I'm sorry if I said we load the cornea. We load the patient with vitamin C, 3,000 milligram daily. Yes.
There is a question whether UBM is better than OCT for evaluation of corneal edema.
Anterior segment OCT is the best tool now for diagnosing, confirming, and quantifying the causes of corneal edema. Of course, corneal edema can be diagnosed by any means, but we're talking about reaching microscopic level of the Descemet and the pre-Descemet layer. And even sometimes you see the endothelial cells swollen on a very advanced high resolution OCT. So OCT is more superior.
Another question is, in chronic case, I mean, after 1 year of surgery with no treatment, can I start treatment and wait or go for surgery from the start?
A long-term established, we said we wait up to 2 months. If it did not recover, this means it's not working. So after 1 year, of course, you need to go for surgery.
If the intraocular pressure is low, for example, 8 millimeter mercury, you still give intraocular decreasing drops?
If this is a tricky question, to be honest. Now, if the intraocular pressure is low and the cornea is edematous or there are Descemet membrane falls, it could be the hypotony is the problem. So no, I do not. But you have to make sure why is the intraocular pressure, let's say, if this is post-op, I would not like it to be as low as 8. I like it to be a little bit more in order to the cornea to regain its function. So sometimes the corneal edema, the striate keratitis is because of the low pressure, and you have to rule out this as a cause of the striate keratitis. Otherwise, no. If the eye is digitally, if the IOP is well, is good and above 12, and the eye is well pressurized, I do give intraocular IOP decreasing drops.
Here I have a question. What is the best way to check the eye pressure in severely edematous cornea? Because we may get false readings. What do you think? Is it, for example, using the air puff, the applanation, the eye care?
Digital.
This is a very important question. All of them, not the air puff. The air puff is the least accurate, because if the cornea is very edematous, the resistance is high. So you're getting a very false result. So if you want just to try it and compare it, but don't rely on it. Not the air puff, of course. ORF, if you have this to see how resistant is the structure is, and the applanation tonometer in case of corneal edema is the best. Although sometimes you have to be careful. The epithelium might be loose, and you might induce abrasion. You have to be careful. You can check if it is really hard with digital pressure, and you can compare it to the other eye. The early stages, because you don't want to induce an abrasion at the first instance. It's difficult to heal.
But of course, if we measure with the applanation, we have to modify based on the thickness, because it is already thick. How about tonopen? Tonopen. Did you try tonopen?
Yes, you can use tonopen. Yes, any touch is doable. Yeah, you can use it. But you have to correlate with the thickness of the cornea, and you can correct the measurement.
Dr. Nancy, do you use Rebasudil eye drops?
Not really. We don't have it, actually. I don't know if you have it in Egypt.
No, I don't have it also.
No, we don't have it in Jordan as well.
Another question after DSAEK, do you recommend the stitch or not?
To stitch the graft to the cornea?
I don't know whether they are asking a stitch to the wound or a stitch of the graft to the cornea.
Now, a stitch to the wound is a must. You have to close the wound properly. It's a 5 millimeter side wound, so you have to close it, because you want to fill the anterior chamber with air. Sometimes I put viscoelastic on the main wound to prevent escaping air from outside the anterior chamber. But I understand now their meaning is stitching the graft to the donor cornea. Some people do it. I've never done it. I've never had to do it. Because especially when the corneal buttons are very thin now, they just stick so beautifully. And after removal, even after removal of the air bubble, it just stays in place nicely. Now, I think if you have a thick graft, sometimes it is cut thick from the eye bank. Or after a multiple detachment, and you want to make sure that it stays in place, you might just put a 1 stitch or 2 in place. But if you reach that stage, I think you have to reconsider the procedure.
What is the choice of topical steroid in herpetic endotheliitis?
It's a must. The most important factor to give patients with herpetic endotheliitis.
Choice of what type of topical steroid?
Yeah, you start with a strong steroid like Pred 40, prednisolone acetate, 1%, for at least 4 times daily at the first few days or weeks until the inflammation infection subside, and then you switch to a milder steroid, Pred mild sometimes, or FML, fluoromethalone, and you decrease it until once or twice daily for if there is scarring and haze, not scarring, if there's haze, you keep it for a longer time to decrease the corneal haze and opacity.
One question is as regard the smile surgery. Is smile surgery causing endothelial injury? He asking about the possibility of causing endothelial injury from a smile technique.
Not that I know of, unless the surgeon just penetrates the lenticule, yes, Dr. Mazen, and he just goes and pushes the endothelium. This is the only way, I guess.
He's asking about the toxicity of the femto laser, for example.
No.
Now, if you go up to 100 micron near the endothelium, okay, there might be toxicity, yes, but we don't go at all near that. So it's safe.
Of course. Unless we are doing like inverted smile.
Yes, the target is very near the endothelium. This is something different.
In which way do you inject an air bubble for a Descemet membrane detachment, and do you recommend a special positioning for next day?
Of course. Now, Descemet membrane detachment, you take the patient to the operative theater and you give some time. And we have two protocols for Descemet membrane for DSAEK graft, let's say, attachment. I'm going to talk about Descemet membrane, and I'm going to talk about DSAEK graft attachment. There are two protocols. You either use air bubble 100% fill for 10 minutes and keep the eye rock hard, and there is a possibility of elevating the intraocular pressure, and if there's a problem with the optic disc, it's a bit tricky and I don't use it, but it's not time wasting because it's only 10 minutes on, or you can use a 100% fill firm eye for 40 minutes. And they use this with the DSAEK lenticule and it works all the time. Now, the other option is that, and I deflate the eye a little bit, I burp the eye from the side, and I keep 70 to 80% air bubble in the AC with the patient lying supine for 24 hours. The first 4 hours are important, and as much as possible, if he can take that within the day and sleep on his back until next day. Now, it's important to dilate the eye or to do a PI, inferior PI, in patients with DSAEK to avoid pupillary block, because you're keeping air in the eye. When it is a Descemet detachment after surgery, you want to make sure that the Descemet is not cut and rolled, because this is different. Even if you put for 100 days air bubble, you will not reattach it. This needs a surgery. But if we're talking about Descemet that has detached from the pre-Descemet or the stroma, and it has detached inferiorly, and you want to reattach it, sometimes this happens after a dark procedure as well. They might not be attached, and the graft could be edematous for some time after surgery. You can go take the patient to the operating room and just put an air bubble for some time, pressurize it well. You have to be careful if the patient is phakic and you want to pressurize with air bubble. This might cause induced cataract. You have to be sometimes gentle. A gentle air bubble will put it back to itself if it is after phaco. If this is a procedure that's DSAEK, let's say, you need to pressurize the eye well for some time, either 40 minutes, 100%, or rock hard for 10 minutes, and then deflate and burp it. Don't let the patient go back home with a hard eye.
Dr. Mazen, we still have a few questions. The time allow us for these questions?
Yes, please.
Okay. There is a question for Dr. Nancy, and he's asking also my experience as regard this point. If you have full or partial Descemet membrane detachment, can venting procedure be done? Can you share your experience, Dr. Tarek? He's asking me to tell my opinion. We listen, yes. Dr. first. Do you advise any venting procedure if you have a Descemet membrane detachment?
Now, if the Descemet membrane detachment happened because there are pockets of fluid, let's say there is attachment of the Descemet, and it's always you do a shine flag imaging or you do an anterior segment OCT, and you see that the cornea is edematous somewhere. Let's say it's edematous inferiorly, but attached superiorly, and you see that most of the cornea is attached, but there are some pockets of fluid, 2 or 3, and you don't want to just take him and put air bubble, because if you put an air bubble, the pockets of fluid will not escape. And at that particular moment, you need to do just a nick in the anterior stroma of the cornea in order to do a price vents, let's say, venting incisions in order to draw the water. And it's important to put when you do this vent incision to put the spear or triangular swab in the place where you ventilate the cornea, let's say, in order to draw the fluid out. And this is the only time that I might use the vent incision. Otherwise, if you have a partially detached graft, if it is attached superiorly and inferiorly it is detached, keep it as it is, wait for it a little bit, maybe a week or two, and it will attach. If the detachment is superior, I always say it's like a curtain. If the detachment is superior, it will detach completely. So take this patient with a superior detachment, even if it's small, to the operating theater, put in a bubble, and allow it to stick all in all.
There is a question also that, is there any intraocular medication that increase the number of endothelial cells?
Not that I know of. We know the Rho kinase for the DSO, as you mentioned, Dr. Tarek. It's not available where we are. I don't think they are being shipped from the States anymore as well. Yani there's a problem now. We're shipping them, taking them, and importing them from the States. But as we said, they are still under investigation. And we're talking about only small early cases of endothelial dysfunction, where you have up to 5 millimeter only of dysfunction or localized areas that you can use it in order to allow the healthy endothelium to proliferate and bridge the gap.
The last question for Dr. Nancy is, do you discover corneal decompensation after corneal cross-linking? Do you have any case of corneal decompensation after cross-linking?
Yes, I did. Unfortunately, I saw a few cases of corneal decompensation after cross-linking that I tried to investigate the reason behind this. We know that the lowest level or the lowest thickness of the cornea that we cross-link for the conventional Dresden protocol, let's say, is 400. We can go sometimes to 350 using the iontophoresis. Now with the Farhad's sub 400 protocol, we can go up to 270, but it's all let's say, controlled procedures. I saw a few patients who have an endothelial dysfunction or decompensation, and I tried to deal with them as a toxic endothelium rather than anything else. And we know that if there was a lengthy time, if the UV radiation was used or abused in this case, sometimes if as I said, it was left more than the usual time, it can reach the endothelium, and this is very dangerous because it can cause toxicity, and toxicity causes decompensation. So we have to be very careful with the protocol we use.
And these cases you have seen, Dr. Nancy, were reversible or permanent corneal decompensation?
Actually, one of these cases was a young man that I had to graft, unfortunately. The other two ladies, they came to me in the first, and I gave a lot of steroids because I thought this might be toxic, inflammatory. Let's bombard them with steroids, and they did recover as long as hypertonic saline drops in order to just draw any fluid that's possible. I think steroid was a game changer in these girls because they just recovered well. But the boy, the young man, it was too bad that I had to graft him.
Thank you, Dr. Nancy, very much for this wonderful
I feel I was an exam.
And no. Yeah,
so much questions.
from the audience, not from me.
Thank you very much. Actually, it was very nice. But I have a comment on about corneal decompensation after cross-linking. Because of the damage that may happen to the endothelium, as Dr. Nancy mentioned, there will be decompensation, but it will be like a beginning of scarring. So the inflammatory process that starts in the cornea will mimic the decompensation itself. So yes, steroids is very, very important. Now, if we want to know why this happened, sometimes even with corneas with good thickness and the usual protocol, this may happen. And this is because the doctor did not pay attention to the distance between the light source of the UV and the cornea. Because in many cases, we just leave this procedure to the nurses to do it, or to the technician to do it, and we don't care about the distance. So usually the distance should be 5 centimeters, but of course it differs from a machine to another. Otherwise, you will end up with such a problem. Now, and I have a question for both of you, Dr. Tarek and Dr. Nancy. As a refractive surgeon, I have a patient coming for refractive surgery, and his topography shows above 600 corneal thickness. When should I doubt about Fuchs or good data? When to go for specular microscopy? Every patient for above 600, or there is a cutoff value beyond which we have to order specular microscopy?
I will let Dr. Tarek answer, because I did not get the question from the beginning.
There is a patient coming for refractive surgery. Of course, we do topography for that patient. I look at the pachymetry of the patient. I find it more than 600 microns. So I have a doubt, maybe this patient has Fuchs or good data or something. So when to order specular microscopy and to doubt? Every patient above 600 or 650 or 700, or what is it?
Do you want to answer, Dr. Tarek?
I don't have a cutoff value, as you have mentioned, but of course, if you have a patient coming for refractive surgery and is a healthy young patient with 600 micron cornea, if you look carefully at the slit lamp, if you find any signs of Gatata, if you find any history in the family for Fuchs dystrophy, you can go for a specular microscopy. But for myself, I don't have a cutoff value when to do such a procedure. Dr. Nancy, please.
Yes, I agree. It's important to go to the slit lamp first. So if you see signs of Fuchs dystrophy, which is a gatata or anything, even if they are the beaten metal appearance, bronze metal appearance, then you can do a specular microscopy to confirm this. Because if there is an abnormal 600 micron cornea, it wouldn't have been, if this is a Fuchs dystrophy, then of course it is swollen. Otherwise, if there's no signs of gatata, this wouldn't have been corneal dystrophy, and this would be a normal 600 micron thick cornea. Because otherwise, if it is a Fuchs dystrophy, this is enlargement. This is swelling of the cornea. You can see it on the slit lamp.
Yeah, that's fantastic, because I wanted by this question to highlight the importance of checking the patient carefully on the slit lamp before rushing to investigations, further investigations. And there is another clue, actually, because, you know, I'm profound of topography. There is another clue to see on the topography, which is the spatial thickness profile. The spatial thickness profile, which is the red curve, we do not see it we do not see it a curve, but we see it flat. When you see a flat one, it means it is a diseased cornea, diseased thick cornea. So you have to think about Fuchs and good data as well. Amazing. I think we have more questions, or what?
I see 19 comments. Do we have time to go through this? There's a question asking about ointment. Shall I ask this?
Yes, this one, please.
Okay, so do I use ointment that apply to sodium chloride ointment? Yes. If you have an option not to use an ointment on the cornea and you have hypertonic drops, please do. I prefer not to use ointment unless the patient is a child and it's difficult to put ointment more often, and you just want to draw fluid out of the cornea as much as you can, as you want. And I don't use the ointment for a long time. I use it twice daily only. I'm not a big fan of ointments on the cornea, to be honest.
Okay, so we came to the end of this session. Thank you very much, Dr. Nancy and Dr. Tarek. We took a lot of your valuable time, and you presented a wonderful talk and discussion. We learned a lot from both of you. No words can thank you enough. Thank you very much.
And thank you, Dr. Hassan, as well, for allowing us to appear in such a a prestigious platform, Sinjab Academy, to reach to all over the world. Thank you for this opportunity.
First, yes, thank you for this opportunity. And this is one of the most interesting and enjoyable sessions, to be honest. I have practiced and participated in. Thank you, Dr. Mazen. Thank you, Dr. Tarek.
Thank you, Nancy. Thank you.
Thank you, everybody, and have a good night. We will upload the
Good
video
night.
very shortly to the YouTube channel, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
Goodbye. Wa alaikum assalam.